This conference will now be recorded.
Good afternoon, all. Am I audible to you?
Yes, ma'am.
Am I audible? Okay. So sorry for the delay. Today's topic is abnormal puerperium. So to say something is abnormal, you should know first what is normal. Before that, you should know what is puerperal period. It begins with the termination of third stage of labor and lasts till all the pregnancy-induced maternal anatomical and physiological changes of pregnancy return to non-pregnant state. So this is the reverse process of the pregnancy. In pregnancy, in 9 months, mother will be gaining weight and different changes in CVS, respiratory system, and all the systems. And all these changes gained in pregnancy will revert back to pre-pregnant state in this period. So just like pregnancy, it is also very important period, and there is a very high chance of infections and mortality of a mother in this period. So we should know what is abnormal in this period to treat as early as possible. Today we will discuss about puerperal infections, perineal infections, and breast infections. In that, first we discuss about puerperal fever. This is very common, and there are many causes for this puerperal fever. Most common cause is genital tract infections. First of all, what is puerperal fever? It is a spiking fever of 39 degrees or higher that develops within first 24 hours of postpartum, and associated with virulent pelvic infections caused by Group A streptococcus. Group A streptococcus is most common organism associated with the puerperal fever. So if a woman gets fever within first 24 hours of postpartum period, then we'll call it as a puerperal fever. Most common cause is genital tract infections. Other minor causes are breast engorgement. In breast engorgement, spiking fevers are less common. Less degree of fevers are common, and urinary tract infections, episiotomy, and abnormal incision infections, respiratory complications like atelectasis. Other puerperal infections are uterine infections. Uterine infection might be endometritis, endomyometritis, and endoparametritis. These are three types with increasing severity. Predisposing factors are route of delivery. Route of delivery is very important to determine the uterine infections. Vaginal route, metritis is infrequent. Increases in women with generally in vaginal delivery, metritis is not common, but there is a chance of metritis in vaginal delivery also in case of membranes rupture, like PPROM or PROM, prolonged labor, multiple cervical examinations, and intrapartum chorioamnitis and manual removal of placenta. These are the cases where we can see metritis in vaginal delivery also. Whereas in cesarean deliveries, it is very common. Single dose of perioperative antimicrobial prophylaxis decreases the incidence and severity of the post-cesarean delivery infections. So we universally and routinely we are giving antimicrobial prophylaxis before or during cesarean section. Ideally, half an hour before skin incision, we have to give antibiotic. Preferably, we are giving ceftriaxone. Other risk factors for metritis are low socioeconomic status, poor nutrition, anemia, bacterial colonization of lower genital tract, and young maternal age, nulliparity, prolonged labor induction, and obesity and meconium stained leg. Coming to the organisms that cause uterine infections, anaerobes like group A, B, and D streptococci, enterococcus, staphylococcus aureus, and staphylococcus epidermidis, E. coli, Klebsiella proteus, and Gardnerella vaginalis. Other organisms like Mycoplasma, Chlamydia species, and Neisseria. Anaerobic organisms also can cause metritis, among them Peptococcus and Peptostreptococcus, Clostridium, Bacteroides, and Fusobacterium are common. Coming to pathogenesis, how cesarean delivery will lead to more chance of metritis. Generally, normal flora of cervicovaginal bacteria on cervical examination or prolonged labor or with uterine incision, this normal flora will be inoculated on the uterine incision, and uterine infection and parametrial cellulitis will occur. So we ourselves are by doing this procedure, we are lodging this normal flora onto the uterine incision, which will lead to uterine infections. Fever is the most important criteria for diagnosis of postpartum metritis. Chills will occur in bacteremia or endotoxemia. Abdominal pain and parametrial tenderness is elicited on abdominal or bimanual examination. Leukocytosis is very common, and we can see leukocytosis ranging from 15,000 to 30,000 cells. Coming to treatment, if the metritis is non-severe, we can go for oral antimicrobials. If the metritis is moderate to severe infection, intravenous therapy should be given. Improvement will occur within 2 to 3 days in nearly 90% of the cases. Persistent fevers are common with the refractory pelvic infections. If the fever is persistent and not relieving after 2 to 3 days, we have to think of refractory pelvic infections, and we should evaluate further. These are the IV antibiotic regimens. Most commonly used or gold standard is clindamycin and gentamicin, which will cause anaerobic and aerobic bacteria. And clindamycin and azithromycin, this is gentamicin substitute for renal insufficiency. Before giving gentamicin, we have to check for RFTs. If RFT is normal and if serum creatinine is within normal range, then only we have to give gentamicin. Otherwise, the second regimen is followed. Extended spectrum penicillins like peptaz, ampicillin, and clavulinate, and cephalosporins, vancomycin, and metronidazole, ampicillin, and gentamicin is used, and carbapenem is also used. These are different regimens, but commonly used one is clindamycin plus gentamicin. Coming to next infections like abdominal incisional infections. This wound infection is common cause of persistent fevers. Other risk factors like obesity, diabetes, corticosteroid therapy, immunosuppression, anemia, hypertension, and inadequate hemostasis with hematoma formation. These are the causes of abdominal incisional infections. If prophylactic antimicrobial is given, the incidence of abdominal wound infection following cesarean delivery will decrease. So we routinely give antimicrobial prophylaxis before cesarean delivery. Incisional abscesses following cesarean delivery usually cause persistent fever or fever beginning about 4th day of the POD, fourth post-operative day. There will be wound erythema. Hospital-acquired pathogens may also be causative. Treatment includes antimicrobials, surgical drainage, and debridement of devitalized tissue. The patient is carefully inspected to document integrity. Before giving antibiotics, we have to first we have to treat the infection and then go for surgical drainage and debridement. Without draining collected pus, there is no chance of healing of the wound. And we have to carefully check for fascia to document integrity. Wound disruption or dehiscence refers to separation of facial layers. This is a serious complication and it requires secondary closure. Most disruptions manifest on 5th postoperative day and were accompanied by serosanguinous discharge. Generally, we do dressing on 4th or 5th postoperative day, so that on that day, if we would notice any serosanguinous discharge, we will start antibiotic prophylaxis as soon as possible. So we have to detect these wound infections as soon as possible to avoid wound dehiscence and treat early. Next one is necrotizing fasciitis. This is relatively less common nowadays. This is a severe wound infection is associated with high mortality rate. In obstetrics, necrotizing fasciitis may involve abdominal incision or It may complicate episiotomy or other perineal lacerations. Risk factors of diabetes, obesity, hypertension are relatively common in pregnant women. These wound complications usually are polymicrobial and are caused by organisms that make up the normal vaginal flora. So most of the uterine infections and wound infections are caused by normal vaginal flora. So we have to very careful while doing vaginal examinations, and we have to give antimicrobial prophylaxis before cesarean delivery to avoid all these complications. In some cases, infection is caused by single virulent bacterial species like GBS, Group A beta hemolytic streptococcus. This is the picture. See, this is very extensive. This is necrotizing fasciitis. In this, we have to remove all this necrotized tissue until we reach the healthy tissue, and we may need a mesh to close the defect. See, this is a highly purulent discharge coming from the wound incision. Infection may involve skin, superficial and deep subcutaneous tissue. In some cases, muscle is also involved. Then we call it as myofasciitis. Most of these necrotizing infections do not cause symptoms until 3rd to 5th postoperative day or postnatal day, except for GBS. A high index of suspicion with surgical exploration, if the diagnosis is uncertain, may be life-saving. If myofasciitis progresses, the woman may become ill from septicemia. So this can be as severe as it can cause maternal mortality. So we have to diagnose early and treat early. Early diagnosis and surgical debridement, antimicrobials, and intensive care successfully treat necrotizing soft tissue infections. So we have to diagnose as early as possible, and surgical debridement is needed. Surgery includes extensive debridement of all infected tissue, leaving wide margins of healthy bleeding tissue. So while doing surgical debridement, we have to remove all the devitalized tissue, leaving healthy margins. Then only the wound will get blood supply and will start healing. Death is virtually universal without surgical treatment. If you don't treat surgically, death is for sure. With extensive resection, synthetic mesh may be ultimately be required later to close the facial incision. As I already told, if the wound is this necrosis is extensive, then we have to remove all the devitalized tissue, and we may need synthetic mesh to close the defect. Another one is adnexal abscess and peritonitis. An ovarian abscess rarely develops in the perineum. This is rare, but it will cause severe peritonitis. So ovarian abscess development during puerperal period is rare, but if it develops, it causes severe peritonitis. So we have to diagnose it as early as possible. The abscess is usually unilateral, and woman typically presents 1 to 2 weeks after delivery. Rupture is common, and peritonitis may be very severe. Peritonitis is infrequent following cesarean delivery. It is most often is caused by uterine incisional necrosis and dehiscence, but it may be due to ruptured adnexal abscess and inadvertent bowel injury to the cesarean delivery. So peritonitis is not a common complication of cesarean delivery. It might occur in case of ovarian abscesses and bowel injury during cesarean delivery. Peritonitis is rarely encountered after vaginal delivery. In most postpartum women, abdominal rigidity may not be prominent with puerperal peritonitis because of abdominal wall laxity from pregnancy. So diagnosis will be delayed because of this abdominal wall laxity. We cannot make out abdominal rigidity. Pain may be severe. So marked bowel distension may develop, and these findings are usually after uncomplicated cesarean delivery. Peritonitis caused by uterine incisional necrosis or from bowel perforation must be treated with surgical intervention. Coming to another infection, for some women in whom metritis develops following cesarean delivery, parametrial cellulitis is intensive within the leaves of the broad ligament. These infections should be considered when fever persists longer than 72 hours. Intravenous antimicrobial therapy should be started. So this is parametrial cellulitis. This is unilateral. So we can see healthy tissue on the opposite side. So usually unilateral and limited to the parametrium at the base of the broad ligament. It may extend to the pelvic side walls. Posterior extension may involve rectovaginal septum, producing firm mass posterior to the cervix. Clinical improvement will be seen with the broad spectrum antimicrobial regimen. Fever resolves in 5 to 7 days. Absorption of induration may require several days to weeks. So next one is septic thrombophlebitis. This is frequent complication in pre-antibiotic era. It is nowadays it is very less common. Septic embolization was common and caused a third of maternal deaths. It means it is responsible for 1/3 of maternal deaths in pre-antibiotic era. With the advent of antimicrobial therapy, the mortality rate and need for surgical therapy for these infections diminished. If septic phlebitis arises as an extension along venous roots and may cause thrombosis, it may coexist with lymphangitis. The ovarian vein may then become involved and because they drain the upper part of the uterus, and therefore the placental implantation site. This is septic thrombophlebitis involving whole of the left side of the uterine left side of the uterus, and it also involve uterine vein, because all this upper part of the uterus is drained into the it has an anastomosis here. So it involves one or both ovarian venous plexus. The clot extends into the inferior vena cava and occasionally to the renal vein. Symptoms improve with the antimicrobial therapy, but diagnosis can be confirmed by pelvic CT or MRI. The addition of heparin to antimicrobial therapy of septic pelvic thrombophlebitis do not hasten recovery. So addition of heparin or long-term anticoagulants do not help in treatment in this case of septic thrombophlebitis. Coming to perineal infections, episiotomy infections rate has decreased. With infection, dehiscence is a concern. Dehiscence is related to faulty repair. Infection of fourth degree laceration can be more serious. Intrapartum antimicrobials were protective against infections. Life-threatening septic shock is rare. It may still occur as a result of an infected episiotomy. Coming to episiotomy dehiscence, other risk factors are coagulation disorders, smoking, and HPV infections. Local pain, dysuria with or without urinary retention are common symptoms. Most common findings were pain, purulent discharge, and fever. In extreme cases, the entire vulva may become edematous, ulcerated, and covered with exudate. Vaginal lacerations may become infected directly or by extension from perineum. The mucosa becomes red and swollen and may then become necrotic and slumped off. Parametrial extension may result in lymphangitis. So cervical lacerations are common and are infected which may manifest as metritis, because cervical laceration, if some bacteria is lodged in the cervical laceration, it can move up to cause metritis. These lacerations, which extend directly at the base of the broad ligament, may become infected and cause lymphangitis, parametritis, and bacteremia. Coming to treatment, infected episiotomies are managed with other infected surgical wounds. drainage is established, sutures are removed, and then the infected wound is debrided. Women with obvious cellulitis, in women with obvious cellulitis but no purulence, close observation may be appropriate. With the dehiscence, local wound care is continued along with intravenous antimicrobials. Early repair after infection subsided is efficacious. Women can develop rectovaginal fistula that may be treated successfully with small rectal flap. Coming to preoperative protocol for early repair of episiotomy lesions. Open the wound, remove the sutures, begin IV antimicrobials. Wound care is by sitz bath 7 times daily. Regional or general anesthesia may be necessary for first flu debridement. Scrub wound twice daily with povidone iodine solution. Debride necrotic tissue. Closure when ephemeral and with healthy granulation tissue. Bowel preparation is needed for 4th degree perineal tears. Toxic shock syndrome. Acute febrile illness with the several multi-system derangements have a case fatality rate of 10 to 15%. There is usually fever, headache, and mental confusion. Diffuse macular erythematous rash, subcutaneous edema, nausea, vomiting, watery diarrhea, and marked hemoconcentration. Renal failure followed by hepatic failure, DIC, and circulatory collapse may follow in a rapid sequence. This is very, very dangerous complication. During recovery, the rash covered areas undergo desquamation. Most commonly, it is due to Staphylococcus exotoxin termed as toxic shock syndrome toxin 1 was found to cause the clinical manifestation by causing sporadic report of virulent group A beta hemolytic streptococcal infections began to appear. Heavy coagulation or infection is complicated by streptococcal toxic shock syndrome, which is performed when pyrogenic exotoxin is elaborated. Serotypes like M1 and M3 are particularly virulent. It is mostly due to toxic shock syndrome toxin 1, and this is very, very virulent, and it can cause maternal mortality. Antimicrobial therapy that includes staphylococcal and streptococcal coverage is given. Women with these infections may require extensive wound debridement and possibly as extended as hysterectomy. Same like to the mother. Last one is breast infections. These are parenchymal infections of mammary glands developed in up to 1/3 of the breastfeeding women. Breast engorgement is very, very common, but mastitis incidence is lower. Almost half of the women will be having breast engorgement, but among them, women developing mastitis is very less, and among the women who develop mastitis, development of breast abscesses is very, very less. So risk factors include difficulties in nursing and mothers with outside employment. Symptoms of separative mastitis appears in third to fourth week of postpartum. Infection almost is unilateral. Marked engorgement usually precedes inflammation. Symptoms include chills and rigors, soon followed by fever and tachycardia. There is severe pain in the breast, and the breast will become hard and red. 10% of women with mastitis develops an abscess. So, women having breast engorgement who will develop mastitis is very less. Among the women who develop mastitis, only 10% will develop breast abscess. Situation may be different and another well diagnosed. Coming to etiology, Staphylococcus aureus is most common cause of positive organism. Immediate cause of organisms are infant nose and throat. Bacteria enters the breast through the nipple at the site of the fissure and small abrasion. The infecting organisms can usually be cultured from within. At times, separative mastitis reaches epidemic levels among nursing mothers. Such outbreak coincides with appearance of new strain of antibiotic-resistant Staphylococcus. Higher incidence of subsequent abscess in these in those with this hospital-acquired MRSA is also associated with mastitis. Coming to management, if appropriate therapy for mastitis is started before separation begins, the infection usually resolves within 48 hours. Abscess formation is more common with staph aureus. Most recommended that milk be expressed from affected breast onto a swab and culture before the therapy is begun. Doxycycline 500 mg orally 4 times daily may be started empirically. Erythromycin is given to women who are penicillin sensitive. If the infection is caused by resistant penicillin producing staphylococcus, the vancomycin or other anti-MRSA antimicrobials should be given. Even though clinical response may be prompt, treatment should be continued for 10 to 14 days. Even though symptoms subsided as soon as 2 to 3 days after starting the treatment, we should not stop the treatment. We should continue the treatment for 10 to 14 days. Breastfeeding should be continued. Abscess may be developed hook with breastfeeding. So even though mother is having mastitis, she should continue breastfeeding. Otherwise, abscess formation will be high. Vigorous milk expression may be sufficient treatment alone. Sometimes the infant will not nurse on inflamed breast, which can make the areola harder to grip. Breast pumping can be used. Suckling on the uninvolved breast is recommended. This will allow let down to the comments before moving to the tender breast. Breastfeeding is in the woman infected with HIV is not contraindicated. In the settings of mastitis or breast abscess, it is recommended to stop feeding from the infected breast because HIV RNA levels will be increased in the affected breast milk. Last one is breast abscess. An abscess should be suspected when there is deference does not follow within 42 to 3 days of mastitis treatment, or when a mass is palpable. Traditional therapy is surgical drainage, which usually requires general anesthesia. In early cases, a single incision or most dependent portion of fluctuation is sufficient. Multiple abscesses, however, require several incisions and disruption of loculations. The required cavity is loosely packed with gauze, which should be replaced at the end of 24 hours by smaller packs. A more recently used technique is less invasive, is sonographically guided needle aspiration is using local anesthesia. So we routinely do this aspiration of the abscess with general anesthesia with the incision, but in this newer technique is sonographically guided needle aspiration. We can drain out the abscess. This is the treatment for breast abscess. So this is ultrasound showing abscess formation. Thank you. Any doubts in this topic? This is very dry topic, but every one of you should know what are the puerperal infections and what are the causes of the infections and how can we prevent them by simple antimicrobial therapy before cesarean sections and IV antibiotics for PPROM and prolonged labors to avoid these complications. So any doubts? Okay, thank you.